Anything that gets your blood racing is worth it. Some challenging situations. The first case is where I was challenging myself. I need to enlarge this rexis. I thought to do it under saline, and you can see after giving a tangential cut, the rexis is being enlarged. The flap you can see is fluttering, and this rexis was completed under saline. The second case was an intumescent case, and I was just debulking, and then I created a flap. I thought this could extend and cause a PCR, but then I took a reverse turn and I used this flap to complete the rexis. My only intention was to cover the initial flap which was trying to extend, and I was quite successful. The third case is again an intumescent tract, and where sometimes you need to deal with the flap briskly, you can see here, and after putting adequate visco you need to pull the flap towards the center briskly. All should be there is the direction should be right, and see I would just hold the flap and pull it towards the center, and see here, yes, and this rexis was almost done, only a small part was remaining, and that too was done briskly. Now the rexis was completed, a little larger though. Now this is the fourth case in which you can notice there is head nodding, and sometimes as a surgeon we are apprehensive, but these cases they seem challenging, but they may not be that challenging, because once your instrument is inside, head nodding comes down a little, and even iris repositor is holding the eye in position, and while doing chopping you note that head nodding is almost not appreciable, although the pupillary dilatation was less. Now I am doing hydroimplantation in the same case in which there was head nodding, and finally I was able to implant the IOL in bag. All you need in such patients is to help them calm down. Now this patient is an albinic patient, and these patients are known for zonular weakness, and you could see that there is a dialysis that is visible. Now, while implanting CTR, I always feel that CTR should be implanted from the side opposite to the site of dialysis, and use two Sinskey's hook. One Sinskey's hook will just take the haptic in, and by the other Sinskey hook, just tap a little and see how nicely it goes within the bag. See here. Yes, and it was gone, and now no laxicity was seen. Now this is the case where I'm doing a SICS while standing. A pinpoint complicated cataract patient had ankylosing spondylitis, and you could see now that there is so much linen kept beneath its head, and consent was taken as patient was unable to lie flat. So I was doing SICS, and I was quite successful in doing the SICS, but I caused a bit of iris trauma here, and which I repaired, and finally I could do this SICS while standing, and this patient had some amount of inflammation in the immediate post-op period, but on a longer term basis he is doing quite fine, and this is a short video showing that I was doing SICS while standing. Now this is a video where I call IOL tantrum, because under hydroimplantation sometimes what happens, your IOL just not behaves the way you want it to behave. Now watch here, the leading haptic is actually turned, and that is what is preventing the IOL to be there in the right place. Now when I pull this, just watch, the leading haptic is turned, and I would just make it straight, and now you can easily implant the IOL in back. So sometimes your IOL they give a lot of tantrum. Now this is a case which is very interesting. Just withdrawing the probe here, see that there is a PCR. So this is again a case which becomes challenging even though the phaco was almost uneventful. And just withdrawing, see the PCR is visible. Now this is another case, you can see the blood clot. There is some vitreous. I did phaco, the IOL was shifting to one side. And when I just noticed this blood clot, I found it fishy. And after bringing it in, see I am counting the vitreous strand, 1, 2, 3, 4. And this blood clot which was outside, that is now inside the anterior chamber. And now this is again a PPC in which I had a nucleus drop, and I am showing how in an undilated pupil, if your rexis is intact, just you can place your 3-piece xylene sulcus. You just need to place the haptic just beneath the iris, and you can push it to one side. The bag is quite stretchable. Now watch here the movement of iris here, yes, and you can see that means the movement of iris shows that there was no vitreous. Now this is a large PCR, but still I felt that I could implant the IOL in back. There is a triangular PCR which would be visible now, and you can see I would be showing here. Now watch, this triangular area of PCR is shown, and now I am trying to place this IOL in back. Actually I thought that still there is support where I could just put my both the haptics, and that would be supported in back, and finally with this large triangular PCR I was able to put my intraocular lens in back. Any challenge can arise out of surgery. So anything that gets your blood racing is worth doing. Thank you for watching this video. No financial disclosure.